I want to start today with something most people never think to connect: their feet and their blood sugar. Your feet are, in some ways, the earliest warning system your body has for one of the most common and most serious conditions affecting adults over 50. Not your blood tests, not your energy levels, not your weight, your feet. The reason comes down to something that most people don't know until it's already causing real problems. The nerves and blood vessels that supply your feet are among the first to show changes when blood sugar has been elevated for an extended period of time, often years before a person is ever diagnosed with diabetes. Today, I'm going to walk through specific foot changes that can be early signals of undiagnosed diabetes or prediabetes, ones that most people dismiss as simply getting older, and explain exactly what each one means and what to do about it. Stay with me to the end, because the fifth signal I'll discuss is the one that catches almost everyone completely off guard, and the one that worries me most when I see it go unaddressed. Hello, I'm Dr. Alex Mandell. I want to be honest with you from the very beginning of this video. Not every foot change after 50 means diabetes. Feet change with age for many reasons: reduced fat padding, arthritis, circulation changes from various causes, skin changes, and more. What I'm going to describe today are specific, particular patterns that are meaningfully associated with how elevated blood sugar affects nerves and circulation over time. These aren't definitive diagnoses, and they're signals. And in medicine, recognizing a signal and acting on it early is often the difference between managing a condition well and discovering it too late to prevent serious consequences. Here's the other thing I want to say clearly: the complications of poorly controlled or undiagnosed diabetes that eventually involve the feet, diabetic neuropathy, foot ulcers, reduced circulation, and the infections that can follow are among the most preventable consequences in all of medicine when they're caught and addressed early. The knowledge I'm sharing today exists specifically to help you catch them early. Let's start with the signal that is both the most common and the most commonly misunderstood. The most common early nerve change associated with elevated blood sugar affects sensation in the feet. And it often begins so gradually that people don't notice it until it's been happening for months or even years. Here's the simple explanation of what's happening at a biological level. Sustained elevated blood sugar gradually damages the myelin sheath, the protective coating around nerve fibers, as well as the small blood vessels that supply those nerves. The longest nerves in your body, the ones running all the way down to your feet and toes, are affected first because they cover the greatest distance. This pattern of nerve damage is called peripheral diabetic neuropathy, and it typically begins with sensory symptoms in the feet before spreading upward. The sensory changes people experience vary. Some describe it as a burning or tingling sensation, like pins and needles that don't go away. Others describe numbness or a feeling of wearing socks when they're barefoot. Some describe a feeling of walking on pebbles or uneven ground that isn't there. And some describe an unusual sensitivity where even light touch feels unpleasant or painful. I think of a patient I'll call Margaret, 66. She'd been experiencing a mild tingling in her toes for about a year before she mentioned it to me. She'd been attributing it to bad circulation from sitting too much and assumed it would come and go. She thought it was normal aging. What happened next surprised her family. When we did a comprehensive evaluation, including blood work she hadn't had in over 2 years, we found her fasting blood sugar had been elevated for what was likely a significant period. She was diagnosed with type 2 diabetes that had probably been developing silently for years. The tingling hadn't been bad circulation from sitting. It had been early diabetic peripheral neuropathy, her nervous system signaling that something had been affecting it. Here's the thing that most seniors completely miss. By the time numbness is the primary symptom rather than tingling, nerve damage may be more advanced. Tingling and burning are early warning signals. Numbness that is significant and persistent is a sign that those nerve fibers are beginning to lose function, and that's when the real danger begins. Why does the progression from tingling to numbness matter so much? Because nerve damage that reaches the point of significant numbness affects what's called protective sensation and the ability to feel pain, pressure, heat, and injury in your feet. A person with intact protective sensation immediately notices a shoe rubbing, a tack on the floor, water that's too hot. A person with lost protective sensation may walk on a blister for days, step on something sharp, or burn their foot in bath water without knowing it. And because blood sugar elevation also impairs wound healing, these small unnoticed injuries can develop into serious infections. Myth versus fact, because this is genuinely important. Myth: My feet just tingle sometimes, and that's normal when you're in your 60s or 70s. Fact, occasional brief tingling from positional pressure is indeed common and normal. Persistent tingling, burning, or numbness in both feet symmetrically, particularly in the toes and ball of the foot, that is present most of the time and doesn't resolve with position changes, is not normal, and it deserves evaluation. What to do? If you've been experiencing persistent tingling, burning, or numbness in your feet, particularly if it is symmetrical, meaning both feet rather than just one side, mention this specifically at your next doctor's appointment and ask for a blood sugar evaluation if you haven't had one recently. If you have diabetes and are experiencing these symptoms, mention them specifically to your diabetes care team as they indicate a need for more careful foot monitoring and management. The second signal is one of the most clinically serious and one of the most commonly brushed off as nothing until it becomes something very significant. Here's what's happening biologically. Elevated blood sugar impairs wound healing through several mechanisms simultaneously. It reduces the function of white blood cells that fight infection. It slows the production of new skin cells and connective tissue needed to close a wound. And it reduces blood flow to the wound site, particularly if there is also diabetes-related vascular disease affecting circulation to the feet. The result is that minor wounds, a small blister from a new shoe, a nick from a toenail cut slightly too short, a small abrasion, heal significantly more slowly, are more prone to infection, and can progress to wounds that are difficult to close. I remember speaking with a 72-year-old patient I'll call Harold. He'd developed a small blister on the side of his foot from a pair of shoes he'd worn to his granddaughter's graduation, a day he described as one of the happiest of his life. He didn't think much about it. He kept wearing different shoes and expected it to heal in a week or two. His children noticed something was changing about 3 weeks later. Harold had started favoring that foot, moving more carefully. When his son asked about it, Harold showed him a wound that had grown rather than healed, now inflamed at the edges and clearly not improving. Harold had undiagnosed type 2 diabetes. What should have been a minor blister had become a wound requiring medical treatment because his elevated blood sugar had created the conditions where minor skin breaks heal much more slowly and infection takes hold more easily. The honest and important message here is this: diabetes-related foot ulcers and wounds on the feet that don't heal are among the leading causes of non-traumatic lower limb amputations in adults. But that endpoint is not inevitable and not sudden. It's the result of a chain of events: undiagnosed or poorly controlled diabetes, an initially minor wound, impaired healing, infection, advanced infection, each link of which represents an opportunity to intervene. The key is intercepting the chain early. Warning sign worth stating very clearly: any wound, sore, blister, or open area on the foot that is not showing clear, measurable improvement after 2 weeks of careful home care, clean, protected, watched, deserves prompt medical evaluation, not more waiting, not another week, prompt evaluation. This is particularly true for anyone with known diabetes, prediabetes, or uncontrolled blood sugar. Most seniors completely miss this point. They assume that poor wound healing is simply what happens when you're older, or thin skin. While skin does thin with age, significantly slow or non-healing foot wounds in the context of other signals we're discussing today warrant specifically ruling out elevated blood sugar as a contributing cause. What to do? Check your feet daily, both top and bottom. This is genuinely recommended as standard practice by the American Diabetes Association for anyone with diabetes or at risk for it. Use a mirror if needed for the bottom of your feet. Any skin break, sore, or wound that isn't healing normally in 1 to 2 weeks should be evaluated, not watched from home indefinitely. This one seems deceptively minor. Dry skin. Surely that's just getting older, right? Or not drinking enough water. In most cases, yes, dry skin on the feet is benign and common with age, but there is a specific pattern of dry, thickened, and cracking skin, particularly affecting the heels and soles, that can be a sign of autonomic neuropathy, a form of nerve damage from elevated blood sugar that affects the sweat glands in the feet. Here's the simple biology. Your feet have sweat glands that are regulated by a branch of the nervous system called the autonomic nervous system. When autonomic nerve fibers are damaged by long-term elevated blood sugar, the sweat glands in the feet reduce or stop functioning. The result is skin that becomes persistently, severely dry, not because of low water intake, but because the glands responsible for maintaining moisture in the skin are no longer working normally. This type of dryness tends to produce a specific appearance. Deeply cracked heels with thickened, sometimes yellowish or grayish skin that resists even heavy moisturizer application. It's different from the ordinary dryness many people experience that responds reasonably well to regular moisturizing. I think of a patient I'll call Dorothy, 69. She'd been dealing with badly cracked heels for years, had tried every foot cream she could find, and had come to accept that her heels just looked like that. Her daughter had mentioned it was time to see a podiatrist. When she finally did, the podiatrist noticed the pattern of dryness was severe and symmetrical and noted that it was worth ruling out neuropathy. She thought it was just dry skin, but when we checked her blood work, her HbA1c, the test that shows average blood sugar over 3 months, was significantly elevated. She'd had uncontrolled blood sugar for an estimated period of years. The cracking heels weren't just a cosmetic problem, they were a potential entry point for infection in feet that were already compromised in their ability to heal and fight bacteria, and they were a signal that had been sitting in plain sight for years without being connected to anything more. A practical note on this signal: not everyone with severely cracked heels has diabetes. Other causes include thyroid conditions, severe vitamin deficiencies, and simply very dry environments. The signal isn't cracked heels equals diabetes. The signal is severely dry, deeply cracked heels that don't respond well to regular moisturizing, particularly in someone with other risk factors for diabetes, family history, overweight, sedentary lifestyle, hypertension, deserve investigation. What to do? If you have consistently dry, cracking heel skin that resists moisturizing, mention it to your doctor along with any other signals from this video. Ask specifically whether a diabetes evaluation is appropriate and whether you should see a podiatrist for foot care monitoring if you haven't recently. This signal involves something most people never think to pay attention to: the color and temperature of their feet, and particularly whether one foot or area of the foot looks or feels different from another. There are 2 distinct patterns worth understanding, and they reflect different aspects of how diabetes affects blood vessels and nerves. Pattern 1. Cold feet with pale or bluish color and slow capillary refill. This pattern reflects reduced blood flow to the feet, a result of peripheral arterial disease, which is significantly more common and more severe in people with diabetes than in the general population. When the arteries supplying the feet are narrowed by atherosclerosis, the same disease process that affects the heart arteries in coronary artery disease, the feet receive less oxygenated blood. They feel cold to the touch, may appear pale or slightly bluish, and if you press on the skin and release it, the color takes longer than 2 seconds to return. Poor capillary refill. This poor circulation compounds every other problem we've discussed. Wound healing, infection resistance, and sensation are all further compromised when the blood supply is reduced. Pattern 2. One area of the foot that is unusually red, warm, and swollen. This pattern can indicate something called Charcot arthropathy, a condition that affects people with significant neuropathy, in which repeated minor injuries to the foot go unfelt and gradually cause fractures and joint damage that the person is completely unaware of. The body's inflammatory response to this unsensed damage causes the characteristic redness, warmth, and swelling. Charcot foot is a serious complication that can cause significant foot deformity if not identified and treated early. I had a patient I'll call Frank, 71, who had known type 2 diabetes and came to me with one foot that was significantly redder and warmer than the other. He'd assumed he'd twisted it somehow without noticing and expected it to pass. His wife was more concerned. She'd noticed the difference a week earlier and had been watching it, hoping it would improve. What happened next surprised even me. The imaging showed multiple small fractures in the bones of his foot that Frank had been entirely unaware of. He'd felt nothing because his neuropathy had eliminated protective sensation in that area. This was Charcot arthropathy in its early stages, caught early enough in his case to be managed with offloading and protection, preventing the significant deformity that can occur if it's allowed to progress unaddressed. His daughter later told me that if she and her mother hadn't pushed him to come in when they noticed the difference, he might have kept walking on it for weeks more. Warning sign: any area of the foot that is significantly redder, warmer, and more swollen than the surrounding area or than the opposite foot particularly in someone with diabetes or known neuropathy, deserves same-day or next-day medical evaluation, not a wait-and-see approach. This is not about alarm. It's about recognizing that the foot in neuropathy cannot always communicate injury through pain the way a healthy foot would. This is the signal I promised at the beginning that catches almost everyone off guard, and it's the one I've seen people live with for years without anyone connecting it to anything. Look at your lower legs and the tops of your feet. Is the hair noticeably absent or dramatically sparser than it once was? Some hair thinning with age is normal, but a specific pattern of hair loss on the feet and lower legs in the absence of other explanations can be a sign of peripheral arterial disease with significantly reduced blood flow to those areas. Hair follicles require adequate blood supply to maintain growth. When circulation to the feet and lower legs is significantly reduced, as it can be in diabetes-related peripheral arterial disease, hair follicles in those areas lose their blood supply and the hair disappears. This is a quiet, visible sign of a condition that otherwise produces no pain or obvious symptoms in its early to moderate stages, which is exactly why it's easy to miss for years. I remember speaking with a 74-year-old patient whose daughter mentioned almost as an aside during an appointment that she'd noticed her father's legs looked completely hairless below the knee, something she'd been seeing for a couple of years and had just assumed was just how he was now. Her father hadn't even noticed. When we looked at this in context with his other risk factors, borderline blood sugar, hypertension, and a family history of heart disease, it prompted a vascular evaluation that revealed significant peripheral arterial disease in both legs that had been completely asymptomatic. He thought it was normal aging, but it wasn't. It was a quiet external marker of a significant circulatory problem, and catching it at that stage before he'd experienced claudication or a foot wound meant he could begin treatment before the window of easy intervention had narrowed. Myth versus fact. Myth: men just get less leg hair as they get older. Hey, it's totally normal and nothing to worry about. Fact: and while some hair thinning can be normal with age, a dramatic loss of hair specifically from the feet and lower legs, particularly in the context of other signals from this video or known diabetes risk factors, is worth bringing up specifically with your doctor rather than assuming it's benign aging. What to do? Look at your lower legs and feet. If the hair is noticeably absent or dramatically sparser, particularly if you're also noticing any of the other signals from today's video, mention it specifically at your next medical appointment. In the right clinical context, it can prompt an ankle brachial index test, a simple painless comparison of blood pressure in your ankle versus your arm that gives meaningful information about circulation to the lower limbs. Here's the most important practical point I can make before we get to the action plan. No single one of these signals is a diagnosis. Each one individually can have explanations other than diabetes or peripheral arterial disease. But when two or more of these signals appear together, particularly in someone with known risk factors for diabetes, family history, overweight, sedentary lifestyle, hypertension, age over 45, the picture becomes significantly more compelling and significantly more worth acting on. I've seen patients who had 3 or 4 of these signals simultaneously for years before anyone connected them. Tingling feet, cracks that wouldn't heal, hair gone from the lower legs, slow healing blister. Each one was seen by a different provider at a different appointment. No one put them together. The power of this video is exactly that. Putting them together for you so that the next time you or a family member notices a combination of these signals, you have the framework to recognize what it might mean and to ask the right specific question. Could this combination of symptoms be related to blood sugar, and should I be evaluated? Step 1, do a foot inspection right now or tonight. Sit in a well-lit area, remove your socks, and look carefully at both feet. Use a mirror for the soles if needed. Look for any numbness or tingling when you touch different areas, any areas of skin that are unusually red, warm, or swollen, any wounds, blisters, or skin breaks you may not have noticed, any cracking or deep fissuring of the heels, and the presence or absence of hair on the lower legs and tops of the feet. This takes 5 minutes and gives you genuinely useful information. Step 2, establish a daily foot check habit. The American Diabetes Association specifically recommends that people with diabetes check their feet every single day because of the combined risk of neuropathy and impaired wound healing. Even if you haven't been diagnosed, if you have risk factors, this is a habit worth starting now. Step 3, know your blood sugar numbers. Ask your doctor, when was my last fasting blood glucose test and what was the result? Has my HbA1c been checked? If it's been more than a year since these were tested, ask for an update, particularly if you have any of the risk factors mentioned or any of the foot signals from this video. Step 4, for any foot wound, sore, or blister that is not healing in 2 weeks, seek medical evaluation. Not another week of watching, 2 weeks of no improvement or worsening equals prompt evaluation. Don't wait for a scheduled appointment. Call and describe the wound. Step 5, ask about podiatry care. A podiatrist, a foot specialist, is an important part of comprehensive diabetes care. If you have diabetes and have never seen a podiatrist or haven't in the past year, ask for a referral. Podiatrists identify foot problems early, provide nail care for people who can't safely manage it themselves, particularly with neuropathy, and are trained specifically in diabetic foot complications. Step 6, wear appropriate footwear. This sounds minor, but is clinically important. Shoes that fit properly, ones with adequate toe room, no pressure points, and good support reduce the risk of blisters and skin breakdown that can become serious in people with diabetes. Avoid walking barefoot, even indoors, if you have any degree of neuropathy. The floor is not sterile, and a minor cut you can't feel can become a significant problem. Step 7, tell the people close to you. Not because you need to create worry, but because the people who see your legs and feet regularly are often the first to notice changes you might miss or dismiss. Harold's son, Margaret's daughter, Frank's wife, family members noticing changes is a recurring theme in every story I've shared today because they were paying attention when the patient wasn't. If you remember one thing from today, let it be this: your feet are visible. The nerve and circulation changes that blood sugar causes over time show up in your feet before they show up in most other places, and they show up in ways you can see and feel if you know what to look for. Tingling that doesn't go away, wounds that don't heal, cracking skin that resists moisturizer, cold, pale feet, or an unusually warm and red area, hair that's disappeared from your lower legs. These aren't random aging changes, they're signals, and signals, when recognized and acted upon early, can change the entire trajectory of what comes next. I think about Margaret, who came to me with tingling toes and left with a diabetes diagnosis and a treatment plan that meaningfully changed her life trajectory. I think about Harold, whose son noticed something was wrong and insisted he get it looked at, and who now has a podiatrist he sees every few months as a matter of routine. Your feet carry you to every meaningful moment of your life, to your grandchildren's events, through your morning routine, from the bedroom to the kitchen and back. Taking 5 minutes to check them and having the confidence to bring what you find to your doctor's attention is an act of genuine self-care with real medical consequences. If this video helped you recognize something you've been dismissing, please act on it. Schedule the appointment, mention the tingling, show the wound, ask for the blood test, and if it helped you, share it with someone in your life who might be walking around with their own unrecognized signals. That share might be the most important health intervention someone receives this year. Thank you for watching. Take care of your feet, and they're trying to tell you something.